Hi, my name is Yamini, and my presentation today is on kinesiotaping in pediatrics. Now, let me give you a brief introduction. Kinesiotaping is commonly known for its use in sports injuries and other orthopedic conditions. It is known to favorably influence the cutaneous receptors of the sensory motor system, resulting in improvement of voluntary control and coordination of children with deficits in these areas. It is known to have its effect on basically strengthening weakened muscles, controlling joint instability, assisting with postural alignment, and relaxing an overused muscle. Now, there are two types of tapes, that is the kinesiotape and the conventional rigid type. The kinesiotape is the more elastic of the two. The rigid tape is the one that is mainly used to limit any kind of unwanted movement in the joint or to protect and support any structure. In case of a sprain or any other condition where you do not want extra movement in the joint or any kind of movement in the joint, then you can use the rigid tape. This rigid tape is also called the athletic tape, and research suggests that it loses its capability to restrict joint motion, which is one of its goals, after a few minutes of exercise. Therefore, it can be said that the effects of taping are mainly due to stimulation of the sensory motor and proprioceptive systems. It conforms to the body and thereby allows movement. The method of application depends on the goals that are to be achieved, whether the goal to be achieved is to improve active range of motion or it is just to adjust malalignment. The variables that are important in this intervention are the pre-stretch, which is applied to the tape, the position of the area to be taped, and the treatment goals. Certain other studies have suggested that kinesiotaping affects the superficial blood circulation in cases where there was an underlying pathology. Few studies have been done, not very many, on the effects of kinesiotaping in the field of pediatrics or rehabilitations in pediatric. There was a study done by Yasukawa et al., which recruited about 15 children between the ages of 4 and 16 who were admitted into the pediatric inpatient program at that hospital where the study was being conducted. The primary aim of this study was to describe the functional hand and arm skills in children after the use of kinesiotape. The study criteria included decreased muscle strength of the upper extremity and/or abnormal muscle tone interfering with the functional movement. The children were diagnosed with various disorders having one or both of the above mentioned impairments, which is either they had decreased muscle strength due to any underlying condition that they had or any abnormal muscle tone. So either of these conditions was the inclusion criteria for this study. The exclusion criteria for this study was the children with sensory and motor loss over the area to be taped. These children were excluded, as well as the ones with spasticity, which is a little higher on the modified Ashworth scale of about 3 or 4. The outcome measure that was used in this study was the Melbourne Assessment of Unilateral Upper Limb Function. The intervention basically consisted of application of the kinesiotape at two areas, from the distal and proximal attachments of the erector spinae from L5 to T2 spinal level using 2-inch tape on both sides of the trunk. This was basically to facilitate a functional upright position of the trunk while sitting in the wheelchair. This was not going to be the main assessment that was to be done. But later, the other area that was to be taped was the right hand from the palm through the web space. This was mainly to provide palmar stability, support the arch, and to facilitate prehension. The thumb taped was to assist with thumb extension. Melbourne assessment was done before and immediately after the tape application, and then there was one done 3 days after. During this time, therapy session was given to the children, which consisted of self-care regimen, mat activities, and tabletop activities. The results were very significant for the Melbourne assessment scores, which improved across all 3 times. That is, the post was better than the pre, and the one 3 days after was better than the pre and immediately after. And there was statistical significant improvement seen between the scores at pre and post taping. This is what the hand function assessment looked like. Before taping, as you can see, the grasp of pellet item 7, the individual is barely even able to open the fist, open the hand in order to reach for the pellet. But after taping, as you can see, there has been improvement in the hand opening and the child is able to at least reach out to the pellet. The strengths of this study was that the Melbourne assessment that was used as the outcome measure had high inter-rater and intra-rater reliability for the population intended to be tested. There was strict inclusion and exclusion criteria. There was one therapist who evaluated all the children to eliminate any kind of variability. There were certain threats or weaknesses also about this study, which was the fact that there was no presence of control group. Therefore, it becomes difficult to draw conclusion whether it was the effect of kinesiotape which brought about the changes seen. Also, during their inpatient stay, they had multiple interventions going on. So it is not possible to speak only of the isolated effect of taping on the improvement in scores of the Melbourne assessment. It could be a culmination of various other factors. Therefore, these are some of the weaknesses of the study. Another interesting study was done by Simpson et al., which aimed to study the effect of kinesiotaping on sitting posture, functional independence, and gross motor function in children with cerebral palsy. There were about 31 children with CP of GMFCS levels 3, 4, or 5 who were recruited for this study. There were two groups formed. One group was of 15, which received about 12 weeks of kinesiotaping intervention, and the other 15 was the control group who did not receive this but received physical therapy. This is what the kinesiotaping application looked like on the children. This is what the area it covered. So this was given for about 12 weeks to the children who were in this group. The outcome measures were gross motor function measures, which is GMFM. Then there was functional independence measure for children, which is VFIM, and sitting assessment scale, which is the SAS. The results indicated that both groups showed significant difference in parameters of GMFCS, sitting subscale, GMFCS total score, and SAS scores, which was P less than 0.05. The significant point about this study was that the SAS scores, which is the sitting assessment scale scores, after 12 weeks were significantly better in the kinesiotape group compared to the control group. The VFIM scores of the KT group were significantly higher compared to their initial assessment as well. The strength of the study was that there was strict inclusion and exclusion criteria. The outcome measures had good inter and intra-rater reliability. All the assessments were done by the same therapist. The fact that the children were randomly divided into intervention and control groups also strengthens this study. One of the weaknesses of the study was the fact that the group of children was not homogeneous. They do not have the same type of cerebral palsy. Also, the effects of kinesiotape was known after 12 weeks, which is a large time period. So it is with the immediate effects of the application were not assessed. Now, studies mainly have always been concentrated on upper limb and trunk. Therefore, there was a pilot study which was done by Losa et al., which was performed to test the effects of lower limb taping on the locomotor function of a group of children with spastic unilateral cerebral palsy. For this purpose, they recruited about 8 children, mean age of 4 years and 8 months. And functional taping was applied for 6 months along with physical therapy treatment was given to the children who could walk independently. The main purpose of the application of functional taping was to limit the movements that caused instability, contractures, or any kind of deformities, and to facilitate symmetrical motor patterns. Ankle taping was applied weekly, allowed to be kept on for 6 days a week, and this was done for 6 months. Required adjustment as and when needed were made by the physiotherapist. The tape was extended to the knee and the hip joint whenever needed. The outcome measures here were the ankle passive range of motion, ankle Ashworth scale, GMFM, and gait analysis. Assessments were done at baseline, after 6 months, and at 12 months. The results indicated that functionally the children improved with respect to their GMFM and gait speed. The locomotor patterns were much more symmetrical in the gait analysis. There were no changes in the ankle ROM and Ashworth values. Furthermore, the changes that were seen in the gait were maintained in the following 6 months as well. That is, at 12 months, the assessments shown that those changes in the gait were still present. The strengths of this study was that different types of tapes were used depending on the goals that were to be met, and required adjustments were made by the physical therapist after 6 months of functional taping. Functional outcome measures were also used. The threats or weaknesses of this study was the fact that the sample size was really small. It was about 8 children. Therefore, the generalizability of the study reduces, and there was no control group present. Therefore, we can conclude that after reading and reviewing all the studies, we can conclude that functional taping is a promising intervention, especially in cases of to improve hand function, to improve sitting posture, trunk function, and even lower limb function in aspects of gait. Therefore, taping can be used as an adjunct to physiotherapy in children with asymmetrical motor patterns, abnormal tone, poor hand function. However, further research has to be done to prove its long-term effectiveness. Thank you.
And these are the references.